Okay, let's do the Kellyology version of Respiratory Emergencies. Obviously, I'm not going to read this to you. You are perfectly capable of reading. So let's scroll on down. One of the things that you can do at home is this. If we had time to do it in the class, we would do that. But this will show you the importance of the lubricating fluid that's between the pleura. You've got the parietal and the visceral pleura, and when they rub together, they create kind of a rub if they don't have that lubrication in there. So that's what this exercise is for. And then the breathe through various size straws, that will give you I call it an empathy lab. It gives you the idea of what it's like to have asthma and sometimes COPD. So different size straws, you got some of those Super Sucker 5000s that you can get from like McDonald's, Burger King. Sometimes they're really big, work great for milkshakes. Even those are difficult to breathe through. So take an opportunity to do that if you can, and that'll help you understand a little bit more about what reactive airway disease or asthma, COPD, is like. In a previous video, I talked about the respiratory system and how it works, the upper respiratory, lower respiratory system, including the diaphragm, chest walls, accessory muscles. This is something I don't think I touched on, but the accessory muscles, the muscles around the neck and the intercostal muscles, those are not normally used to breathe. Anybody that's using those are usually having some type of problem breathing. It may be normal, it may not, but those accessory muscles are something that you can visualize. Something else that somebody that may be struggling to breathe will do is, we call it pursed lip respirations, and that's where they put their lips together and blow out like that. And what they're doing with that, if you remember videos that we looked at earlier about PEEP, that's basically what they're doing with pursed lip respirations, is they are creating their own PEEP. So COPD patients, it's not uncommon to see them do that. Somebody, again, that's having trouble breathing, where their lungs are collapsing, the alveoli are collapsing, having that pursed lip respiration will keep them open. It creates that positive pressure inside the chest. Remember, everything above the vocal cords is considered your upper airway: nose, mouth, jaw, oral cavity, pharynx, and larynx. That's your upper airway. The lower airway starts at the vocal cords and includes the bronchus, the bronchi, and then all the alveoli and those things that are down inside the lungs. Now, I spoke in the video the majority of the time talking about respiration, ventilation. This is something I struck this. I've seen this in the book several times, and this is not correct. What they're calling respiration is not inspiration and expiration. Ventilation consists of the two processes, inspiration and expiration. Inspiration is an active process. They have to work to do that. That includes the diaphragm and all the muscles around the chest. That is an active process. Expiration is a passive process. So basically, once they inhale, they relax, and the air comes out. So inspiration is an active process. Expiration is a passive process. In normal, healthy humans, the brainstem senses the level of carbon dioxide that's in the arterial blood, and that is what tells the body whether or not they need to breathe, or it tells the brain whether or not it needs to breathe. So the brainstem senses the level of carbon dioxide that's in the arterial blood, and this is what tells the body whether it needs to breathe slower or faster. Remember, carbon dioxide is the waste products from the body. So if the carbon dioxide levels start to get high, then the body is not getting rid of the waste as it should, so they need to breathe faster. If the carbon dioxide levels are low, then they have too much oxygen, so they need to slow their respirations down. And that's how the brainstem works, as compared to the hypoxic drive, which we'll talk about momentarily. I already talked about the different processes that can alter the exchange of oxygen, carbon dioxide, whether it's abnormal pathological conditions, whether it's disease processes, trauma, and even abnormalities in the pulmonary vessels, sometimes birth defects. Those things can cause that. What is important is that as an EMT, we can recognize the signs and symptoms of inadequate breathing and know what to do, and also not just inadequate breathing, but respiratory distress. So let's go over a few of those, one of which is the use of accessory muscles, where you see it in the neck where they're trying to breathe. You can generally walk in, we call it a Kellyology. I didn't coin the phrase. It was one of the ER docs, but he calls it the looks like crap. If you walk in and they look like crap, there's a problem. You need to figure out what the problem is. So if they're really struggling to breathe, you'll see accessory muscles, the use of accessory muscles. If they're not getting good oxygen exchange, that's where you start seeing the cyanosis. The other things that are commonly seen with people who are struggling to breathe, they do not want to sit down or lay down. They will generally be sitting what we call bolt upright. So they're sitting right on the edge of the chair, leaning forward, so that they're trying to compensate for the fact that they're having trouble breathing. So sitting straight up, using accessory muscles. I've seen them standing up. I've seen them standing in front of a fan. The fan blowing in their face made them feel like they could breathe a little bit better, similar to a mild version of CPAP. So those are some of your signs and symptoms of respiratory distress. Other things that you may hear wheezes, you may hear stridor. The difference is stridor is that real high-pitched sound that's like and you will hear that whether it's inspiratory or expiratory. And then wheezes are a very mild version of that. You don't hear it generally without the use of a stethoscope. If you can hear wheezes without the use of a stethoscope, then they are generally in a pretty significant distress and need action quickly. With the hypoxic drive, that's the backup system that generally patients will have that are long-term COPD, asthma, those types of folks. And their body's used to working off of the amount of oxygen that's in the blood, not the amount of carbon dioxide. That's what they call the hypoxic drive. And like I've said before, the Kellyology behind that is, the theory is that because the hypoxic drive works off of the amount of oxygen, the theory is if you give them too much oxygen, that significantly more than they're used to, then their body kind of goes, oh, hey, look, we got way more oxygen than we need. We're not going to need to breathe for days. And so they stop breathing. So that's kind of the theory behind that. But again, can't stress it enough. If somebody needs oxygen, provide them with oxygen. Do not withhold oxygen from anybody who needs oxygen.